Welcome to another episode of Marvelous Medicine. We are very happy to tell you that we have already completed 70 episodes last week. Today's topic is on the ethical challenges in organ transplantation in India. Who gives, who lives? And to talk about it, we have Dr. Sanjay Nagral. He's the Director, Department of Surgical Gastroenterology at Jaslok Hospital. He did his MBBS and MS General Surgery at GS Medical College, Mumbai. Dr. Nagral then went on to do his fellowships in King's College Hospital and the Royal Free Hospital in London. He has more than 100 publications in index journals and has edited 2 surgical textbooks, apart from contributing to 6 textbook chapters. He is the publisher and member of the editorial board of the Indian Journal of Medical Ethics and the chairperson of the Forum for Medical Ethics. Dr. Sanjay writes on issues related to public health, medical ethics, and organ transplantations in newspapers and other forums. He co-edited the book Healers or Predators, Healthcare Corruption in India. He was the joint secretary of the Zonal Transplant Coordination Committee in Mumbai. Dr. Sanjay was nominated to the Executive Council of the Declaration of Istanbul Custodian Group, an international organization working on transplantation ethics, and has recently been nominated as its co-chair for the years 2021-22. We couldn't have anyone better than Dr. Sanjay Nagral to talk on this topic. Thank you, Dr. Sanjay, for readily accepting our invitation despite your busy schedule.
Moderating
the session. Sorry. Yeah.
Yes. Thank you, Dr. Vidya, and thank you to your group for inviting me. I must say that you said readily, but you know, I think I once agreed and then backed out. So this is the second time that I committed, and I was a little worried today because I was held up in a case till 7 o'clock, and but I managed to extricate myself. I said second time would be terrible, and I can say that I did attend one of your sessions a few weeks ago, the one on surrogacy, briefly, and found it very interesting. And I know your group now, and I'm also feel privileged to have with here today moderating my talk 2 people whom I not only know well, but whom I think are, and I'm not somebody who praises people very easily. So when I say something about people, I mean it. 2, I would say, very good thinkers in the organ transplant space in India. Dr. Amlor, of course, everyone knows, and Sonal Astana. And both of them actually have done a lot of, given a lot of thought to this topic. And therefore, I'm a little nervous, actually, with the 2 of them there about what I'm going to say, because these are people who have worked in the field, and I'm sure we'll have a lot to say. Now, when you first approached me, Vidya, we thought whether we should talk about ethics in general, and I think that can be quite boring, to put it crudely. Certainly makes it very difficult, and I myself always avoid topics like that. But perhaps what I'm going to do today, and what I do more often, is to actually take a subject like transplantation, not because only because I have insight into the subject, because it brings out some of the ethical challenges and principles better when we talk around in the context of a certain activity. And transplantation particularly lends itself to ethical challenges, as I shall try and share with you. So I'm just going to start sharing my screen with this title, which is a little, can you see my first slide?
Yes.
Yeah, so actually, as you can see, I changed the wordings here. I finally chose the term ethical quagmire rather than ethical challenge, because I think some of the things I'm going to share with you, I'm just going to put them to you as a quagmire, not necessarily preach to you, or not even necessarily give you unilinear narratives or answers, but just to bring out the kind of problems we are facing. So just a introductory slide on what I'm going to try and cover today. Here is a list point-wise of what I'm going to attempt to cover today. So the first, of course, is why is ethics especially relevant to transplantation? Some of this is intuitive, but I'll just quickly address that. On the other hand, how does transplantation actually challenge classical ethics? So we'll have a quick look at that. Before I jump into the transplantation challenges, ethical challenges, I think it's important to look at what's the big picture. We are almost 3 decades after the Human Organs Transplant Act. And therefore, it's a good time to look back at what's the big picture in India. I would also like to address what's unique to transplantation in India. How does it differ from the rest of the world? Because it has some implications for the ethical challenges. And then, of course, I will look at certain ethical quagmires. And I've put them here. So here's a list. So dead enough to donate, but not dead enough to die. So you'll know what I'm talking about within 10, 15 minutes. Everyone should donate, but everyone can't receive. That's a major ethical quagmire in my view. And the woman as a live donor, is this a sacrifice? Is it or is it pressure? And finally, I would just like to take you back to the fact that actually what we're going to discuss maybe in transplantation is actually a lens to larger ethical questions in healthcare. And therefore, I'm going to end actually with certain quick slides on what is it that modern medical ethics actually attempts to do. So let's start with this statement. Arthur Kaplan is a very prominent ethicist, and he says this about the field of organ transplantation, that it is very, what is distinctive about it? It's I think, again, obvious that that it is different from other fields because you need an organ and somebody needs to give an organ. And if nobody gives organs, there would be no transplantation. So what it therefore means is that we need individuals as well as people in general to participate in this process. And that puts a certain burden on the way we conduct the transplant activity. But going a little deeper, why is ethics guidance especially relevant? Why are there so many codes around transplantation ethics? There are at least 4 or 5 major global bodies who have come out with ethics codes, including the Declaration of Istanbul, which now I am a part of. But why is all this necessary, specifically for transplantation? So here are some reasons. It's a life-saving procedure with a massive demand-supply gap, and which is actually widening. Transplantation is a victim of its own success. So the more successful it is, the more the gap is going to widen, because the more are going to be people seeking it, the more are going to be the indications emerging, and therefore the gap is actually going to widen the more successful it becomes. It has very limited availability in the globe and even inside a country. So transplantation today means for a large majority of the individuals traveling somewhere, either one part of the country to another, or very often across countries. And this has its specific challenges. One of the things in a live donor transplant, and of course, many of you are people involved in healthcare and surgeons, so you know this, but it needs to be reiterated that for that individuals, actually, there is really no health benefit. So we are not doing an operation on a healthy individual for a health benefit for that person. So the benefit is actually a conceptual benefit. Now, how does that play out? Because after all, it is an operation on a healthy individual. So that's one of the peculiarities of the live donor operation in transplantation. I don't think in any other field one operates on a healthy individual for the benefit of somebody else, putting that healthy individual at risk. So this is a particular unique thing in transplantation. A deceased donor organ, and I'm assuming, of course, that all of you know what is who constitutes or what constitutes the term deceased donor, is donated as a public good. So this is another concept that we need to understand, that there is a concept of a public good, and therefore that public good, how is it supposed to be used? So that's another burden on the transplantation activity and transplantation community, because this is doctors are not usually used to dealing with public goods. Doctors are actually uniquely used to dealing with private goods in their day-to-day work. So when it comes to public goods and I think it is especially challenging, and I have found this very challenging when I have engaged with colleagues, because when you bring up issues of public good, public interest, and conflict of interest, etc., many of my colleagues seem to ask me, what is this all about? How is it relevant to what we are doing? So I think this is a concept that is rather alien to our day-to-day work. And finally, of course, given this background of the fact that there is so much of demand-supply gap, this is fertile territory for inequity, abuse of power, inducement, coercion, whatever you. So when you have that background, of course, you need some watchdogs, some principles, so that there is at least a sense of order, and there is a sense of propriety, if not a very high sense of justice and ethics, which we will come to. But transplantation also challenges traditional ethics in many ways. And when you apply the principles of traditional ethics to transplantation, this has been actively challenged. So, for example, should all ethics rules apply to situations which are life and death situations, or can there be exceptions? So that is one question that has been raised. Are you translating from routine situations to life and death situations? A bigger question which I deal with almost on a very regular basis now, because we interact with global bodies, is that the universal values, how do they clash with local realities? So, for example, in global transplantation ethics, there is a concept of self-sufficiency. So countries are supposed to have self-sufficient in their meeting their demand for treating organ failure, whether it is dialysis or transplantation. But the fact is that is absolutely not true in most LMICs, most developing countries. So do the universal global values, which are espoused from a perch of the advanced West, where there is a fair amount of self-sufficiency, not complete, of course, should they be applying to the rest of the world? So that is another challenge to global ethical principles. But even more interestingly, and even more in a more contemporary fashion, do notions of ethical problems with concepts like trading in human organs, do they apply in modern market economies, where everything is anyway commodified? Is the owner of the organ the king? Which means that can the owner decide what should be done with the organ? And this issue comes up in many ways in transplantation. Does the owner have the individual autonomy to decide whom the organ will go to, what price will be charged for the organ, etc.? Because there is also a principle of autonomy in. So these are things which have been turned around and argued also. And finally, is there a role for a regulated, transparent market with interest safeguarded in transplantation? This is a school of thought which has emerged in the last few decades, and like many other sectors of the modern economy of many countries, including India, is there therefore time to rethink on having a market in organs, which is regulated, which is transparent, and where all interests are safeguarded? So classical ethics has also been challenged by even ethicists in the domain of transplantation, in terms of the application of the principles to contemporary situations. And countries have actually, even with ethical oversight, experimented with regulated markets in transplantation. just go to the next point, which is the what is the big picture of transplantation in India? And I think, as I said, we are at almost, if that was indeed a landmark, the 1994 Human Organs Transplant Act. Although, of course, transplantation preceded the HOTA in India, kidney transplantation, not liver. But it is considered a landmark in many ways. So we are a good 28, 30 years. And as I said, it's a good time to look at what's happening. Now, these are maps from the Global Organ Transplant Registry, which is run by the Spanish. A lot of good data out there in case any of you is interested in transplant data, lovely maps and charts, etc. And this is 2020. Now, I must say that 2020 is not a great year to look at because of COVID. So we know that during COVID, transplant numbers did go down all across the world, including India. But this is the latest data, and I chose to use it. So this looks at the total numbers. And as you can see here on the right, so India performs a significant number of transplants now. The big dots are, of course, the US here, China here. But the map on the left, the colors, is what actually gives us the number of transplants performed per million population. So that's probably a better reflection of what a country is doing to provide its citizens the services of transplantation. And therefore, if you look at that figure, India is somewhere in the middle, and we are certainly similar to many countries around us, certain Middle East and African countries, but we are a big country. We are a big country. So we can take pride in the fact that we actually are somewhere in the middle now with respect to our number of transplants per million population, except with one caveat. And I'm going to come to those caveats soon, but that actually this will have a small number of patients who are foreigners and who receive transplants in India. That figure, I think in liver could be about 5-10% range. Maybe somebody like Sonal may tell us, and kidney probably could be a little lesser. Here's another look at what happened in that year. And as you can see, India is sort of, if you look at numbers, third on the global charts now, very close to Brazil, sort of sharing space. So in terms of numbers, India now is actually doing significant numbers of transplants. And here is how it grew. This is a chart from Noto. And here is how transplantation grew from the 90s to now. And as you can see, after the HOTA, there have been a proportion of deceased donations and live donors. Live donors still predominate. And again, there's a chart which I did not put up, or a map I did not put up, but which is that for some reasons, and again, this is, I think this is something worth thinking about. Only some parts of India do deceased donation and some parts don't. And therefore, that map is also skewed. So when you want to look at transplantation in India, I already told you that the numbers are now significant. There has been a significant growth. But when you start looking at what's actually happening on the ground and some details, so it's very non-uniform across the country. And I'll soon show you a map, a little old map of where the transplant centers are. So it's very much a urban metro activity in about 5 cities of India. So that's, you can safely say that there are 4 or 5 cities of India who do 95% of transplants, at least when it comes to liver. Kidney may be a little less. There is very limited deceased donation still. So a majority of the transplants are live donors in India. And this is very different from the West, but this is very similar to countries in Southeast Asia and countries like Japan and to some extent Korea. China is a different discussion, which we may or may not want to go down that route. But so we do mainly live donor transplants. I think the big difference between India and most countries of the world, and now I have actually looked at many countries of the world who do transplants in significant numbers, is that the domination of the private sector is rather unique to India. And when I say domination of the private sector, I mean a complete huge domination. So I'll show you some figures there. Finally, India is also now sees substantial travel for transplant from other countries. And this is, I think, both kidney and liver, but certainly significant numbers in liver. What this means and who are these people traveling, I'll come to in a minute. But here's a look. This is the Mohammed Rela's paper. It's a little old, but they plotted these liver centers. And you can see how ununiform the liver centers are. Again, big cities, for 4 or 5 big cities seem to do everything. And then they have also plotted the deceased donor activity. And this is also very interesting. So it is the South and the West, most of you know this, that seem to have substantive progress in deceased donation. And why this is so is, I have my views on this, but we could perhaps take it up if somebody wishes in the discussion. Now, here's a chart from our editorial piece in Transplantation last year, which is a table which we prepared with some effort, which looks at, this is 21, which looks at the estimated needs of transplants for various organs in India. This estimated need, of course, is a rough figure. And, we do not have the kind of data that many countries have, but this is based on multiplication of OPD data, et cetera, et cetera. So it's projected data. But if you look at the estimated need, the number of transplants we are doing obviously are almost minuscule. And that's a fact across the entire developing world, or LMICs, and in South Asia, that we still do very, very limited numbers of transplants compared to the problem of organ failure. And in the kidney, actually, even dialysis is still a big challenge. We know that. The cost issue I will try and look at again. But what is the point to note here is that this costing is based on a wide range, based on whether it's done in the public sector or the private sector. And you'll see this wide range between the public and private sector. But what is interesting is that if you convert this figure into US dollars, which is what we have done, this is extremely costly for our citizens, but extremely cheap for somebody coming from the West or from the developed world or from the richer countries like the Middle East. So this is something worth noting, because this is one of the explanations why people travel to India. I put a red mark here on the public sector involvement, and I think 5% for liver is even optimistic right now. I would say it is even lower. Kidney, the proportion is substantively higher. But when you go down other organs, but still grossly dominated by the private sector, and this is very different from many countries. This seems peculiar to not even South Asia, because even Sri Lanka is different on this front. So this seems particularly peculiar to India, Pakistan now, where the private sector is taking off in a big way. But otherwise, it seems unique. And the source of organs, live much more than deceased donor, is something which I already mentioned. So I'm going to come to the first point, the first ethical, and as I said, it's a quagmire. I've used the term quagmire. It's an ethical quagmire, which is the role and dominance of the corporate health sector in transplantation. So let's, you all know what is the corporate health sector. I'm not going to sort of describe it. Many of you know it. Many of you work in corporate hospitals. So, but what I just want to say here is that the characteristic of the corporate health sector makes it particularly suited to an activity like transplantation. Because transplantation involves huge capital investments. It is a focus of these hospitals. Medical tourism is a priority area for these hospitals, because this is the for-profit sector. So obviously they will invest in these areas. But what corporatized healthcare also means is, and which is where the slippery slopes can start, which means that therefore there are targets for clinical teams. The pays are often linked to numbers, performance, etc. And this is very entrepreneurial activity. So when there is entrepreneurial activity with sometimes even conflicts of interest, because doctors are owners, shareholders, what have you. So that is going to lead to, on one hand, a lot of energy and drive. And we must recognize that energy and drive. But on the other hand, it is leading to huge conflicts of interest. And I think this is again unique to the Indian situation. But I must say that this dominance of the private sector has had lots of positive fallouts. I think the rapid growth we have seen by the standards of other LMICs is related to the growth, the push by the private sector. The high level of expertise and innovation, and we must actually acknowledge that we are seeing lots of innovation, surgical innovation in transplantation in India. Because what's happening is that one is attracting high expertise, and because of the relative shortage of organs, people are even innovating. And this is also attracting Indian clinicians. There's a huge number of Indian surgeons and physicians who are trained in transplantation, training in transplantation. So they are now being attracted back. So this is, one can say from a national perspective, a good fallout. Some of these centers are becoming high volume centers, and in transplantation, volumes matter in terms of outcomes. There is no question. They are able to perform very rapid workup. And in certain situations, this is very useful. I've already talked about innovation. The costs actually being the private sector are variable and even bargainable. Now that you can actually see both ways, but can even be an advantage. And therefore, there is facilitated transnational movement of patients, because tourism is a big activity for these centers. What it leads to, what are some of the challenges, I'll just come to in a moment. But the first ethical quagmire I want to put to you from a public perspective, put yourself as an average common citizen of India. So it seems to everyone that this activity, whilst being cheap for foreigners and is attracting foreigners, is unaffordable for our ordinary citizens. If you look at the average annual income of Indians, and I'm talking of course, ordinary citizens. So that is the first big ethical quagmire in my view, which is that activity which involves a public good, an activity which involves public participation, the message that is coming out is that this is activity which is largely meant for a certain class of people who can afford very high charges. The medical tourism story is a little more complicated and are again a quagmire, because in India, medical tourism is perceived as a national pride. So it is, of course, revenue for the country. It is a substantive revenue to the private sector. Does it mean that it translates as subsidy for locals? Is a question. It could, if there is a conscious mechanism to do that. And therefore, actually, medical tourism in India is actually facilitated by governments and local embassies. But when you have travel for transplantation, you can have specific challenges, because there are no direct MOUs between hospitals, between governments. So you have people traveling. Language is an issue. Who certifies relationship? There is always a higher possibility that when people are traveling from another country, you are actually doing unrelated donors. And there is data to show that amongst those who come from foreign countries, the chances of having an unrelated donor who's posing as a related donor is significantly higher. Finally, of course, the public perception of foreigners in a hospital coming for transplant, whether it for ordinary people, whether it brings up memories of the kidney trade of the 80s and 90s. Those of you who are young may be not aware, but once upon a time, and I'm sort of embarrassed and ashamed to say this, that the city I work and including the hospital I now work, it was famous for basically Arabs coming for kidneys, for buying kidneys from ordinary Indians. So those are this. And of course, it can lead to this fallout. Now, I know this is a very complex story, and I know that Amal will have maybe some details to tell us or something else to say, but you have the same media which supports us and has been very actively pushing the cause of disease donation. A whiff of the sort of foreigners jumping queues or foreigners getting priorities is enough to bring down the public perception of the activity. So what is the dominance of the private sector does on disease donation? And I know many of you, I think this group is based in the South and especially in the state of Tamil Nadu. And I think Tamil Nadu, you knows disease donation now in and out. But what it therefore does is that, there's a large number of potential brainstem death individuals in public hospitals, but donations are coming from private hospitals. And I think clearly to me, this is because private hospitals are interested in the donation. And why are they interested in the donation? Because private hospitals get the organs for their own patients. I think it's time to accept certain things because then we can move on. There's no altruism here. This is not about public altruism. This is about actually a drive towards getting organs for patients listed in your own hospitals with exceptions. And this is why I think the dominance of the private sector, whilst pushing towards donation, has given the whole image of this activity as a elite project by the private sector and has kept public hospitals away. I know I'm saying a lot, and I know that I'm saying some very loaded things, but perhaps I thought I should be a little provocative here. So the current allocation protocols in most states, and which allows the first use of organs. I know I'm going into some detail here, and I apologize to those who perhaps may not be aware of the details here, but when there is a deceased donor whose organs are available for distribution, there are protocols for how they are to be allocated. And if currently in most states, they are allocated first to the hospital in whom where the donor is situated, because this was started as an idea to promote disease donation. But that is exactly what is pushing those hospitals to push the donation. But that is exactly how most organs are either coming from private hospitals or are going to private hospitals. So I think this is a sort of quagmire which we are facing. And therefore, the allocation criteria in a deceased donor organ is a matter of great ethical debate all over the world. What should be the allocation criteria? Should it first go to the person who's the most deserving? Should it go to the sickest person, irrespective of who that person is, which hospital, what is his ability to pay, etc.? And I think this is one of the big challenges in India right now, that we, in the early years of disease donation, brought out criteria which talked about chronology, rotation, which was the idea was to promote disease donation. But what therefore happened is, because the private sector dominated, the system slowly got gamed. So for example, if there is a donor who needs to fly, the organs need to fly, the cost is put on the recipient, at least in my state. And therefore, what it means is that the recipient who can afford to pay for the organs to be flown will obviously get the organ. So slowly but surely, when these are the kind of, so when it is not a state activity funded by the state, when it is not a public project funded by the public, it slowly invariably gets sort of, you can say, either gamed or biased towards those who can afford to pay for all these activities. So this is a quagmire which I shall leave you with, because I'm going to come back towards the end of my talk on a fundamental principle of modern medical ethics, which is justice and non-discrimination. But I think that this is the quagmire we are facing. The second is a little shorter, but a little more complex to understand. And I shall try and attempt to explain it to you. So the Human Organs Transplant Act was brought in for two purposes in India. The first was to curb the commerce in organs. It was rampant at that time in the 80s and 90s, and everybody thought that this should be cracked down. It was becoming embarrassing for the country, actually. So the government took interest, and but then there was a simultaneous push to also legislate and legalize the idea of brainstem death or brain death. Now, I normally, when I give these talks, I try and explain what brainstem death is. I would not do that today because by now I think most people know what this is, and this audience certainly would know. But I think there was a error or a fatal mistake made here, which is that in one act, you had two things happening together. Part of it was about transplant, the organ trade, and part of it was brain death. And therefore, the two got linked. And conceptually, it seems that the brain death definition in this act is only in the context of organ transplantation. Conceptually, that's one easy and lazy interpretation of the act. There are, of course, two views on this, but since it has come in the Transplant Act, one lazy and I would say easy interpretation is that therefore this applies to transplantation. But what does this do? So on one hand, the idea of promoting disease donation, what it did for the last 20 years is it turned a spotlight on something we had ignored for many years in this country, which is the end of life care and futile care. So actually disease donation was one of the windows which opened out. But end of life care began to be seen in ICUs in the narrow confines of brain death. So transplant coordinators would go and say, is there anybody brain dead? They sort of, so there was no connection with the larger problem of futile care, because you can have individuals who have terminal illnesses, who have getting futile care in hospitals, who are not brainstem dead. So therefore, also what happened is that if somebody did not donate organ, and this still happens, some states are trying to come out of it, is that if some family says no to donation, the life support, or that's the wrong term, but the ventilator is not switched off. So in effect, what we are saying is that we can take organs and turn off the ventilator after taking the organs. But if the organs are not being donated, we will continue to ventilate that individual. Now, this is a sort of, it's not just a huge ethical transgression, but it's, I think, even a legal transgression. But this, we have lived with this for the last 20 years. And I think the reason this happened was because I think what really happened is there was a premature kind of utilitarian push by interested parties. Who was the interested party? The interested parties were people like us, including me. So we pushed the idea of disease donation without linking it to the larger area of futile care and end-of-life care. And as a result, we have now this situation. And here's Sunil Shroff and Sumana Naveen writing about what we now need is a uniform definition of death, because we otherwise have two types of death, and therefore with circulatory death we give a death certificate, with brain death we only give a certificate if their organs are donated. And I did this piece here, and I have tried to get into this issue of why this happened, because I think brain death and the push for disease donation preceded the movement towards end of life care and what is now called passive euthanasia. The Aruna Shanbag case came later. And now we have Supreme Court judgments which say that we must have some mechanism in this country to withdraw care in terminally ill patients, in persistent vegetative states, in those with futile care. And it's a matter of time before this legislation is coming. But what we really need to do, therefore, is to link the idea of brainstem death as one of the elements of futile care, and which is what many countries have effectively done. I come to my last and third quagmire, and this is again very short, but it is a reflection of something else, which is slightly different from what I've been discussing, which is the woman as a live donor in India and the gender question. And here's some data. This is rough data taken from publication, I've tried to round off the figures, but here it is. So transplant recipients, 80% are males. Deceased donors, this is Mumbai data, 65% are males. But when it comes to live donors across the country, and this also includes, by the way, the state of Kerala, which is, I think, would say is matriarchal, which is, where the woman is perhaps very differently placed in society. 80% of live donors are women, mothers, sisters, daughters, but largely wives donating to husbands. So what is this? What is happening here? The woman as a live donor. So this whole gender question. Is it the caring gender? Is it why they donate more? Is it considered a family duty? And I've had transplant coordinators arguing or presenting the case strongly that finally it is the woman who should donate, because finally the male is the breadwinner. So it is the duty of the woman to save the life of the breadwinner of the family. Or is this our patriarchy pressures? Is this an internalized self role of the woman in our society who sort of thinks that it is her duty primarily to save the life of those around her? But certainly there are transplant marriages, and certainly that phenomenon has been seen in India. So the reason this is also important in live-related transplants is, and I'm not going to discuss the live donor risks, etc. That's a huge discussion. Today I thought I'll restrict myself to these 2 or 3 quagmires. But I just want to bring this in, that whenever we talk of live-related transplantation, especially liver, much more than kidney, whilst we have pushed towards it, whilst it has lots of advantages, especially in terms of a quick transplant, but there is that constant lurking point or issue in the wings, which is donor complications and donor death. And donor death is very much a reality. We do not know the exact figure from India, but I can share with you that the figure is not inconsequential. And I have personally been involved in auditing 2 donor deaths in the city of Mumbai in the last 1 year. So it's not an inconsequential figure. So just to summarize now, just to come to the last 5 minutes of my talk. So are these ethical quagmires in organ transplant really unique, or actually are there lens to Indian healthcare? I think that's one question that I would like to pose. And if one really looks at it from a little broader perspective, they are actually not unique to transplant. They are probably receive more attention because the stakes are higher, because the media interest is higher. Whether it is patriarchy and the way the female gender is treated even by healthcare, whether it is the dominance of the private sector and the various slippery slopes and the monetization of healthcare, and whether it is some of the policies that are pushed by interest groups in India. These all are some of the fault lines of healthcare in general in India. So whether it is lack of universal healthcare, the retreat of the public sector, the influential pressure groups who set the agenda. Who sets agenda in healthcare in India? It's a very interesting question, but it is clearly not a democratic agenda. It's individuals who are powerful. And I think this is exactly what even happened in transplantation. And societal biases reflect in healthcare, and societal biases, social hierarchies reflect. So finally, and this is, I just thought I'll just turn it around for you a little bit. When Vidya first talked to me, she said, can you talk on medical ethics? And I said, it's very boring. It's very theoretical. And therefore, as I said, I just thought that I shall put to you the quagmires and challenges in transplantation. And just while leaving you, bring you back to what I think is really the sort of what I have perceived as the ethos of medical ethics, which is this, that actually the origin was from the idea of justice. We often perceive medical ethics as the doctor-patient relationship. Of course, it is a doctor-patient relationship, the behavior, the way we deal with patients, etc. But the idea was, there were two other powerful ideas here. One was the idea of justice, but it is also a very powerful idea of a social contract with society, wherein we were given the monopoly to practice medicine in return for society expecting us to behave in a certain way, regulation, safeguards. And in fact, therefore, I often say now that ethics is not such a moral idea, but it's actually an idea of professionalization of medicine and legitimization of medicine. And I think the more we think about it and the more we connect it to our day-to-day work, include whether transplantation or otherwise, it is these principles are all not just ethics principles, but it's also making our work more professionalized in whatever we do. And these are the classical four principles of modern medical ethics. If any of you is interested, this is all there on the net, and I'm not going to discuss these principles, but this is what people go back to again and again. So beneficence, non-maleficence, autonomy, but finally also justice. But this is interesting. So many professional organizations now in countries are moving away from calling it ethics to calling it professionalism. And many departments of ethics now are called departments of ethics and professionalism. And therefore, now they are looked at as principles of professionalism rather than just putting it in the ethics paradigm. But they are the same principle: the primacy of patient welfare, patient autonomy, and social justice. And that is how ethics has expanded in the last few decades to many areas. And if you look back at really what I shared with you in the last 45 minutes, it is an expanded understanding of what ethics should look at. The reason I'm talking to you today partly is to do with this journal. And I'm going to share with you in the next slide a very interesting and intriguing fact. But before I do that, I just want to share with you the fact that this journal is now survived for 30 years. And this journal is now indexed for many years, probably the only voice on ethics from South Asia in the global community. But this journal survived without any ads, with no relationship with the pharma industry. And I make it a point to say this because there is a feeling amongst many of us that professional activities, CMEs, journals cannot run without pharma involvement. So this is an example of that, the fact that we've struggled, we've had major struggles. We have almost collapsed very often, but it has survived. And I think now it will survive because it's being noticed. But this is interesting, and I'm going to leave you with this because I know this group is, I think, largely surgeons. So out of the 5 editors of this journal, the first 4 were all, or are all, not were, but are. They're no longer editors, but they are surgeons. And I often wonder, what is it that is about surgery that sort of made them connected to ethics, or it was just happenstance or just coincidence? I'm not sure. But the journal was started by Dr. Sunil Pandya, who's a neurosurgeon. Dr. Arun Bal, a diabetic foot surgeon, took over. Dr. Nandi was who many of you know, and I think he's participated in some of your sessions. And I think there was an attempt made to get him.
He's there now, Sanjay. He's on the audience.
Oh, he's there. Oh, I'm sorry, Dr. Nandi, if you're there. I'm going to say that Dr. Nandi was our editor for a brief period, but played a very big role in reviving the journal. Then you had your very own George Thomas, who could not come today for reasons I don't know, but I don't know whether he's also there, who was the previous editor, and Amar Jasani, who's the editor now, who's the only non-surgeon. So I'm going to leave you with this slide, and thank you for sort of tolerating me for almost 45 minutes. I'll be delighted to get responses, questions, and take part in the discussion. Thank you for your attention.
Thank you, Dr. Sanjay, for that lovely talk. Though most of you know, I will just briefly introduce Dr. Amalokanathan, who's going to be one of the moderators. He's a vascular surgeon at Vijaya Hospital in Chennai. He did his MBBS and MS General Surgery from Madras University and MCH Vascular Surgery from Tamil Nadu Dr. MGR University. Dr. Amalokanathan was the transplant coordinator in Government General Hospital, Chennai. He was designated as the convener Cadaver Transplant Program Tamil Nadu in 2008. The Transplant Authority of Tamil Nadu was formed by the government on 12th December 2014, and Dr. Amalokanathan served as the member secretary of Transplant till 2016. He is currently a member of the State Planning Commission of Tamil Nadu, and we cannot talk about organ transplant in Tamil Nadu without taking his name. Joining him will be a transplant surgeon, Dr. Sonal Asthana. He's the clinical lead, hepatobiliary pancreatic and multi-organ transplant surgery at Aster CMI Hospital, Bangalore. He did his MBBS and MS surgery from JIPMER Pondicherry and his ASTS fellowship at University at Alberta. He's involved in hepatobiliary pancreatic surgery, liver transplant, kidney transplant, pancreas, and small bowel transplant. He has authored more than 40 peer-reviewed papers and has won international awards for basic and clinical research. His other interests are cell transplantation, surgical oncology, translational research, health policy, entrepreneurship, and medical ethics. Already Dr. Sanjay told you how both these people are on the forefront of making transplant more equitable. Over to you, Dr. Amal, sir. Please unmute yourself, sir.
Thank you, Dr. Vidya. Thank you, Dr. Radhakrishna. And Sanjay, I sit here, what shall I say, shell-shocked, because that's how I become when I hear people like you who have been in the field guiding the country in transplant and in ethics. I was just imagining if I were asked to present what I would have done any differently. And I don't think I have anything else to add, Sanjay, except that when I was starting in this field, when kidney racket was rampant in Chennai, so I had one of my favorite slides those days. That slide just had 4 lines. The donor is always a female, and the recipient was almost always a male. The donor was always younger, the recipient was always older. The donor is mostly poor, and the recipient was mostly rich. The state of live transplants 20 years back, without the law, with so much of regulations, etc. I think the situation remains largely unchanged. Even today in our country, transplant is affordable only by the rich, and it's mostly out of societal support. The poor cannot and do not have any access to any tertiary care. Liver transplant as one of the tertiary care areas in the country. So I think it's largely kept outside public purview. The reasons are obvious. I mean, we discuss so much about transplant in a country where even today, as we are speaking, 50% of our women
Amal,
are
if you can switch off your camera,
increasing.
you can hear better, Amal, because the bandwidth seems to be low. You can switch off your camera and speak.
Let me try all this. Stop. Yeah. So even today, about 50% of our women are anemic in this country, especially women who are pregnant. And about 20 to 30% of our school-going children are wasted and stunted. So, are you going to offer transplant in public sector hospitals, compromising your primary care? Is one of the dilemmas that several state governments are grappling with, and even Tamil Nadu is grappling with. Today is also the World TB Day, and the largest number of fresh cases are from India. and about 30% of the global burden of TB is in India and among mostly women. So where do we juxtapose all these against transplant? So I think all said and done, transplant would remain mostly in the realm of private sector only, and some poor people might get it as a charity or supported by some NGOs or some crowdfunding, but that's about it all. And I would like to know what Sonal thinks. I'll stop here.
Over to you, Sonal.
Sure. Thanks a lot, Dr. Amlo, and thank you, Dr. Nagral. I think you made an excellent start. It is normally traditional for moderators to praise the speaker, but you started by praising the moderator, so you sort of disarmed us right at the get-go. I think that's a very smart move. I'm going to use that in the future. I'm going to steal that from you. I mean, your talks are interesting as always because they help us see certain challenges from a different lens. And certainly, I have really enjoyed how you've used this as a lens to transplantation as a lens to ethics in the larger picture. I mean, I've just finished a transplant, as it happens. Again, the donor was a woman, and so it is something that is obviously it's very current and very relevant. Two things sort of stand out in what you have said to me. Firstly, about transplant being a reflection of healthcare, the larger problems of healthcare. And the second is the healthcare being the reflection of the larger problems of society. So I think that we have to be very careful about making judgments about transplant outside of the context of the society that we live in. Okay. So, for example, a lot of the discussions that we have talked about for the private sector in terms of inequity, etc., are true for non-transplant activity as well. But perhaps they are more poignant in transplantation because of the involvement of a donor and the involvement of either a deceased donor organ, which is a public good, or an interested voluntary donor who doesn't have any direct health benefits, as you said. So I think that is probably a very important or a unique lens to look at transplantation. Regarding the other part, which Dr. Amlo also talked about the context or the role of transplantation in a place like India, I mean, I think the same argument can be made for India not having a space program, for example, or a missile program, because certainly, I mean, there's no getting away from the fact that we have a large number of impoverished people. Another interesting lens that I read about recently was actually India being divided into three classes called India 1, India 2, India 3, which is India 1 is sort of, the rich people of and approximately 10% of the population with a population or a socioeconomic status like Mexico. India 2 is socioeconomic status of certain Far Eastern countries. And India 3, which is 50% of the population, having the socioeconomic parameters of almost sub-Saharan Africa. So I think that there are those huge inequalities that we are talking about, certainly. I don't think that we can plan or legislate only for one particular segment of India. Certainly doing transplantation, raising the quality of the services that we offer will benefit everyone in the long run. So there is a strong argument for transplant to be done in the private sector, not just for reasons of equity and justice, but also for the reasons of quality of the care that is provided to people who come to those private sectors, to the public sector organizations. I saw one question about the data outside. Actually, sadly, this is very consistent data. The predominance of female donors in the living donor sector is very consistent data from across the world. It is just more pronounced data. So more than a majority of the donors across the world, living donors are women. So it's again, it's just not just an Indian problem. It is a global phenomenon that we're looking at. So yeah.
No, you complete. I just thought you'd finish. Sorry, continue.
No, I think those are the 2 points. The point about the role of transplantation in the public sector, as well as transplantation also reflecting the larger realities of society. I think those are both well-made points. That was just a counter to perhaps what Dr. Amla was putting across.
Right. Thanks, Sonal. We are very privileged to have Dr. Samiran Nandi, who without him, we wouldn't have had the Transplant Act. Sir, your opinion on the quagmire of ethics in organ transplantation. Could you unmute yourself, sir? Sir, please unmute yourself.
Can you hear now?
Yeah.
Yes, sir.
That Indian medical care has changed tremendously since Patta Radhakrishna and I were working together to try and change the law, and a lot of other people too. And at that time, as people said, as Sanjay said, that kidney trade was absolutely rife. And I used to go to Birmingham to learn about liver transplant, and they used to call, doubtful donor as a given Bombay operation, because India was was a pariah in the transplant world. And to defend the act, we thought that if we abolished trade, we have to have a substitute. And the substitute would be deceased donors. And the main transplant activity would be in the public sector. And we were interested mainly in liver transplant. But what happened was that it's evolved into liver transplants being done in the private sector with live related donors. But I must say that one of the major failures of the act was that an appropriate authority was established. And the appropriate authority would not only recognize hospitals, but would have data on all transplants done everywhere with the results. And this has never happened. Now, the argument against this is that why don't we have data on appendicitis? Well, we should have data on appendicitis. But the thing about transplant is that it's a very major procedure. 2 people are involved. It's very expensive. And I want to end by saying that I don't think that we should treat the rich and the poor the same. We never do. And I was on many panels, and I have to say that there's no point in doing a liver transplant on a beggar outside the All India Institute if he's dying of hepatitis related cirrhosis. It is better to do it. We have to change our whole mindset about the value of certain human lives. But I think that when people ask me what I consider my major achievements after returning here, I think one is training people like Patta, and second is the Transplantation of Human Organs Act. Because I think the Transplantation of Human Organs Act has changed the face of Indian medicine.
Thank you so much for joining us, sir. We have Dr. K.R. Balakrishnan, who has done the maximum number of heart transplants in India and perhaps many parts of the world. He doesn't have the quagmire of live donors. Your thoughts on today's topic and any input, sir?
Yeah, thank you for asking me to join. There are 2-3 things that we need to remember. One is the field of heart and lung transplants in this country is extremely different from the liver and kidney because, as I said, there is no living donation involved, number one. Number two is, as a consequence, a large number of donations happen in sites and cities far away from where the recipient is. In fact, just to give an example, just yesterday, we had 5 donor calls, out of which we took 3 organs, one from Calcutta, one from Chandigarh, then 2 calls from Ahmedabad, Bangalore, and I think Coimbatore. So imagine the amount of logistic nightmare you need to be able to handle in order to go all the way. And the next is the information that you have about a donor is often sketchy. And by the time you reach, say from Chennai to Chandigarh, the donor could have become unstable and the cost has to be borne by somebody. So these are huge dilemmas. And I'm not sure in our lifetime, this is going to be resolved anytime soon, considering our expenditure on healthcare is a miserable 1.5% of the GDP. Having said that, whatever the number is, it's inconsequential. On the other hand, I must also highlight the fact that increasingly a lot of state governments are funding transplant activities in private hospitals, and Tamil Nadu actually took the lead. And they give us, I think, 16 lakhs for a heart, and I think 20 or 25 for a heart, and for a lung and a heart lung.
20 for lung.
20 for lung. So while these may not be enough for every patient, they are something. And the very definition of poor and rich, in my opinion, is not black and white. A lot of patients, by the time they come to us, have spent their money in so many other hospitals, in and out of hospital admissions. And even an average middle-class patient becomes poor if they get stuck with this kind of therapy. So that definition is also needs to be looked at. And number three is every effort is also made to raise funds for every single patient who comes to the hospital requiring a transplant. But in my opinion, at this point in time, it may or may not be possible, even for well-established central institutes to run successful. For instance, the reason we keep going to Chandigarh to pick up organs is at least in the area of heart and lung, they don't have any significant activity in the area of heart and lung transplant. So the one thing state governments ought to do, in my opinion, because significant cost of transplant activity is laboratory tests which are reliable and which are expensive, especially immunological tests. I mean, to get a donor-specific antibody or a single bead antigen, these things cost a lot of money. And on a recurrent basis, liver may not face the kind of rejection issue that we do. So even if you do a successful transplant on the basis of funding and send these patients home, what do you do when they come back after 3 years requiring readmission or other therapies? So one area in which, in fact, if I remember, I had discussed this with Dr. Amlor when he was in the center of activity, was whether the state governments can be requested to put up a high quality lab centrally, which provides laboratory services around the clock with reliable results, for which they charge a reasonable amount. And that ought to be and could be repeated in centers across the country. That could be a start for increasing participation of state in transplant activities.
Thank you, sir. We have Dr. Amar Jesani, the editor of IJME. Would you like to say a few words, sir?
Is Amar there?
Yeah, perhaps he logged out in the past few minutes.
Yeah, he was there a few minutes back.
I did.
Oh, yeah, I know. I think he's logged off. Okay.
So, Ilango, you had some questions. Would you want to voice them?
Yeah. Thank you for the wonderful talk, Dr. Nagral.
We can't see you, Ilango. Can you switch your camera on?
I think the bandwidth may be a problem, but I'll get on the video. Okay. So thank you for the wonderful talk, Dr. Nagral. It's nice to see you, and it's a pleasure to hear you organize your thoughts. So I had an imagination like this. Can we imagine something like a Medicare or a Medicaid based on an additional income tax cess and a link to the PAN card, so that access to transplantation can be made uniform across India? We are charging cess for pretty much many things. I think a small quantity on this would go a long way to help out. And what are your thoughts? We have Professor Nandi and your thoughts too. And that goes a long way to help affordability. What we find is that the Tamil Nadu government scheme actually helps in the time during the time of transplantation, and we are supporting them for 2 years now in our hospital. But it's very difficult for the individual families to maintain the required transplant requirements after that time frame. We are trying to help them out, but it is still very expensive. And that continuing care gets missed, and there is a lot of problems that happen down the lane. We are looking only at data that says 1 year survival rate. And most of us get that good survival rate. And for advertisement purposes, a lot of people talk about immediate survival, which is actually pretty good for most programs. But the long-term survival is pretty dismal. It touches somewhere around 60% in programs that have lasted more than 5 years if you actually look at the data. It's a lot of people who fall off the grid. It's quite a bit of severe rejections. We still have gaps in that. So if we imagine something like a Medicare or Medicaid, would that help?
That's my question. Sanjay replies that, can I invite Professor Subramaniam, a senior urologist and one of the early persons to do kidney transplantation, and his views on this?
Yeah, I think this has been a wonderful lecture. I think the narrator has taken extreme precautions to use the correct words, not to hurt anybody, but bring out all the things, faults, which he feels it is there. Unbelievably presented well. The words you chose, it is the fact. Whatever you said is true. And I think the disparity between rich and poor, when it is there, it will always be there in sophisticated medical procedures, because we don't have a correct answer. Every life is important. Everybody is important. Everyone, for the family, the contribution to the society, providing employment to people. So this is a very delicate thing. So at that, especially when the disease program is on, your focus is more on sorting out the minor issues, accept few things, hurry up with the procedure, see that quality care is delivered to the patient concerned, and the organ starts working immediately. These are all any medical person's ambitions. So to counter the economical challenges which is provided by the transplant at world at large, it is, unless the country grows like US, economically self-sufficient, everyone can afford it. We have to wait patiently, and we can't stop the procedure or the interest you have cultivated to do a hard work and attend to patients. You've got to grow, see that is grown further and further, so that the endpoint is reached earlier. And I salute the speaker today. I have not met him before. I have not heard about him also. Sorry, sir. And your lecture was wonderful. The words were all chosen perfectly well. I don't think you can have another word in your slide for what you wanted to convey. And that was a sort of a presentation. But please accept all these challenges. Go ahead and continue working. I'm quite sure there is a hope at the end of the tunnel. You will have a day when everything will be sorted out, when poverty is eradicated from this country. But you got to be patient. And for that, we can't just keep our eyes closed for the modern aspects in transplants, especially what Bala is doing now is unbelievable. 600 cardiac transplants. You can imagine those patients' families, how happy they are, how much they will be able to contribute efficiently because of that. Family members is protected and saved. So please think of positive things, and people like Sanjay should keep at it in that perfect way. For example, if I had taken to it, I started taking it to it at the early stage of my career. I didn't use the proper words. I didn't have the language for it at that time. And I didn't have that mindset and maturity. So I've heard some people at that time. Then I quietly sat over this topic, and I didn't want to get much involved in this ethical. I remember in the Madras first MGR Medical University, I was the one allotted this topic. to talk on ethics. Rangabashyam sir was chairing the session, and his comments, all that still fresh in my mind. But we have come a long way. Definitely, only the medical people can contribute this way to society by saving lives. That is what we are meant for. I agree there will be problems and challenges, but people like Sanjay will come now and then and guide us the right way and remind us what is in store. People like Bala will be doing more technical achievements, and Patta Radha Krishna, what work Nandi himself was the first man in the field who inspired with his lecture in my initial days. So he is appreciating Patta. So there are a lot of talents. We are going the right way. Please pursue it. Don't be disheartened. Definitely, you will be paving the way for a wonderful future. And thanks for the time allotted. Thank you.
Thank you. Can I just, so first of all, thank you for your kind words, sir. I don't know whether I really deserve all that, but thank you. It makes one feel good. But I just want to respond to some of the points. Do we have the time, or is this the right?
Yes, yes. We have all the time. All the
Okay. So, obviously, there are many problems, and obviously some of them are beyond our capacity to correct. But I have a problem, and which is that whilst there are health policy issues, whilst there are issues of funding, I think on the other hand, I don't think we are doing enough as a community. And I refer to partly the transplantation community and partly to the larger community of healthcare professionals to try and do two things. One is, given the limitations, to improve access. And therefore, I'm not talking of very, very huge goals of, let's say, campaigning for increase in the health budget. Of course, we can do that, and some of us and many of us are doing that, and there are organizations working on that. But what I'm just saying is that even given the challenges, I think I'm sorry to say this, but many of my younger colleagues are getting co-opted into the ideology of the hospital. And I think one of the first things we need to do as professionals is to separate ourselves from the ideology of the hospitals we work in. Because, all over the world, you see professionals and professional organizations actually have a distinct view from their employers or from their from where they work. And I don't see that distinct view. And I think that's important. There is possibly also conflicts of interest, which I mentioned, but I think that's point number one. So for example, I've been saying repeatedly, and I put this proposal, I'll share this with you, that I put this proposal in, for example, in Mumbai more than once, very formally, that why don't we have a process where we consciously have some ways of affirmative action in disease donation. And there are two ways to do it. One is, we say that every fourth organ compulsorily goes to a public institution. You can debate about whether fourth or eighth, but that it goes to a public institution. So that's one way of affirmative action. And the second, and this I put to government, is that since everybody is donating, so it's a public good, why don't we have a policy where every 8th transplant or 10th transplant in a private hospital is done for a public hospital patient free? Because finally, how are we going to go to people? How are we going to go to people and say donate organs when a large number of them will be thinking in their minds that, okay, fine, you want altruism from us, but what about if I need the organ? So I'm just saying that whilst we wait for the change, whilst we wait for universal healthcare, and of course, Ilango's idea of alternative sources of funding. So you create specialized systems like Medicaid, Medicare. Of course, by the way, a very interesting piece by Sunil Shroff and John Gill in AJT last year, and I think I think, Sonal, you know about that piece, where they actually proposed a mechanism where a fund is created by private hospitals who benefit from deceased donation to fund public hospital programs or public. So a lot of these kind of internal mechanisms, at least to demonstrate that we as a group of professionals are willing to do this. And incidentally, I must share this, that article was roundly criticized on certain WhatsApp groups in India, saying, who are these foreigners to teach us what to do in India? So, we also have this mentality. So I think whilst we wait for the move towards universal healthcare as and when it will come, I think our own efforts, and Sonal has been spearheading many such efforts, the affordable transplant program, etc. Because I think if we are talking of a public activity where we want to involve everyone, we need to demonstrate our intent to make it more accessible. So these were, and just one more quick point. I think doctors in India have the capacity to punch well above their weight. They are influential people. They are influential with politicians. They're influential with political parties. And I think we must use that influence to actually improve access. The old issue that Amal raised at the onset of the fact that India is poor and therefore we are struggling with basic issues. But the fact remains that this very thinking which may have led us to ignore, I'm not talking of transplantation now, but ignore quality tertiary care or quality specialist care with our focus on primary care, and including emergencies, trauma care, treatment of various medical emergencies, because the focus was on primary care, and rightly so. But the fact is that one saves lives with quality tertiary care also. So I think that's something we need to look at. Because to say that we will do transplantation only in the private sector because of a host of reasons, but we want the country to be part of a campaign to donate organs is incongruous, if not hypocritical. So I think that's the point that I have been repeatedly making. I have absolutely no illusion that suddenly people will listen to this and there'll be a sudden change of heart. It won't happen. There are compulsions of the private sector. I know those compulsions very well. But then are we as a group, are we as a professional body at least trying to push in a certain direction? I have a quick word on philanthropy and crowdfunding. And this is something we must think of, that whilst crowdfunding is playing a big role in India, a very good role, especially for pediatric transplants, I think even crowdfunding organizations are going to, and already have and will in the future, ask the question, are we funding the profits of private hospitals? What are the private hospitals doing in return? So even the individuals in crowdfunding who donate are going to say that, look, we are donating, we are giving personal charity, but what's coming from the private sector as charity? So that's also something we must keep in mind. That
you said something on the, every fourth transplant is done in the government sector. We must make sure that the facilities available in that government hospital is 100% same as the private hospitals. The support system, all that we must make sure. Then only we can put these sort of guidelines. In other words, we have to develop overall. Overall development will sort out all these problems. But as academicians, it's our duty to do continue to do without getting upset. I agree, these are all genuine issues, but don't get upset. You be at it, you will have your day. And again, your observations were wonderful. Thank you.
That's Sonal.
Yeah. I mean, I just wanted to respond very quickly to the, as Sanjay knows, the work on philanthropy and CSR was, we'd started some of this about 4 or 5 years ago. And we've done more than 120 pediatric transplants that have been supported through crowdfunding. And I mean, the questions are probably as interesting as the talk, because as we can see, we cannot separate ethics from economics. And that's very, very important for a country like ours, because equity would only be a word if we don't create a mechanism for people to actually benefit from that equity, both in terms of the quality that is offered in the government hospitals, as well as the funding to pay for transplant. Somebody has to pay. So, I mean, it's always helpful. What helped us was actually breaking this down into smaller parts. The question that Sanjay asked was asked to us by a lot of our corporate benefactors as well. Why would we pay and support a hospital's profits? What is the cost of a transplant? And surprisingly, nobody knows the cost of a transplant. And when you talk to people, they'll get numbers anywhere between 7 lakhs to 30 lakhs. That's a very, very big range. And a lot of the initial work that we did was actually breaking down the costs. And radical transparency was the only thing that helped us, where we were able to break down the costs of every activity of a transplant, which was done along with IIM Ahmedabad, so that we could do something called activity-based costing. I mean, we learned a lot from that process as well. So the answer to probably Sanjay's pointer is radical transparency. And certainly there is a lot of sort of inward introspection that private hospitals will have to do as well, because the same private, same liver transplant in crowdfunding, one is asking to raise 10 lakhs and somebody else is asking to raise 30 lakhs. So certainly, the persons who are actually contributing will ask that question as well, not just the platform. One of them is obviously not telling the truth. So I think that we do have to introspect, and certainly you should have some common agreed upon parameters by which costing is decided. Because when you talk to a government hospital, they will tell you the costing in terms of the medicines that are bought in a bag, and as we used to do in AIMS, and used to give people a list of the medicines to buy before an operation. So but that's the consumables are not just the cost of an operation. So unless if you want to make it sustainable, you have to factor in the costs of paying for personnel, paying for medicines, and the ongoing care that is required for the entire operation. So we used activity-based costing for that. That has led to some good academic work, and more importantly, it has created that transparency that is required, that gives the comfort to people who donate to these causes as well. So I think that works both ways, and certainly creating a sort of a common field where we are able to ensure that the cost of a good is the same, whether it is being done in hospital X or hospital Y, is an important part of what we need to do if we are to ask other people to fund it.
Vidya, can I have a minute?
Yeah, yes, sir.
Yes, we know that people like Dr. Sonal and Dr. Bala are trying very hard to bring a very expensive procedure affordable to most people. I know Sonal has done extensive work on costing, etc. But I also know that many of the leading transplant surgeons are constantly seized of these questions and trying to do their bit. But does it or will it change the transplant scenario of the country? What are the factors that deter? Now, Sanjay was telling about every fifth case being done free in a private hospital, or every fifth organ is offered to the poor man, the public hospital, etc. Now, all of us are talking about this for 20-25 years. But what are the factors that are deterring from getting this into practical reality? So just think for a moment, Sanjay, what is preventing it from Maharashtra? What is preventing from Tamil Nadu? What is preventing from every other state? There must be something organic which is preventing this from happening, from becoming a reality. So unless we understand those factors, this will be our very, what shall I say, pious wishes, which may not come true.
No, absolutely.
And in fact, one more thing, Sanjay, one more thing.
Sure.
Now, we all know that tertiary medical care today is extremely expensive, gadget oriented, and without the help of industry and private sector, this amount of excellence or good results cannot be achieved. And the public sector will be certainly lagging behind because they cannot dream of the investment that the private sector can do. So the only way that the country can progress is, you might consider this lofty, but I don't see any shortcut unless the country invests in public health and in health in particular and in public health especially. We cannot go the Europe way at all. So without money, nothing is going to move in public sector. However much the surgeons and physicians struggle in public sector hospitals, they are never going to match the tertiary care sector of the private hospitals. So the key lies in the country making a commitment that they will spend at least some more amount on their budgets. Unfortunately, I'm not seeing this happening in any state. In fact, if at all, it is gradually declining. Thanks.
Right. So just a few quick responses. I was about to say that there is a question or a comment in the chat box, which is sort of on similar lines, which says that the key ethical dilemma is who should drive the public good, the state or private enterprise. Thoughts, inequality and difficulty in access and distributive justice cuts deeper and begs greater socio-political question. That is the elephant in the room. Absolutely. So it's a political question, and I think investment in healthcare is a political question. And I have no illusions that you and me sitting here are going to solve it. If the Aam Aadmi Party wins an election based on healthcare, we can temporarily feel good about it. Or if some other party tomorrow decides to make healthcare the primary way, which we should all probably help them. So you and me are not going to solve it. I am just making a very limited point, which is, I know it's a very limited point, which is that given the, and by the way, Amal, I didn't, maybe I used the word lofty, but not in the sense that it is unachievable. Countries have achieved it. So not lofty as in unachievable, lofty in the current Indian scenario where we seem to be stuck in so many identity issues that for us it seems lofty. So I'm saying that the limited point I'm making is that one of the things we need to understand why we are not making progress on disease donation, because that is our all of us is because it's actually not a public activity. It's an activity of individual hospitals driving it, and that's appreciation we need to have, and some firefighting in terms of opening it out, drawing in public hospitals, PPPs or whatever may help. But you're absolutely right that it is not a national activity as yet of the state of India wanting to provide transplantation to its citizens, or for that matter, organ failure solutions, even dialysis. So that I'm clear about. I thought Tamil Nadu is doing a much better job because now it's funding at least a lot of things, including in the private sector. PMJAY is now funding kidney, and I just had an interaction with a very senior PMJAY official who says that they are seriously considering even liver. So PMJAY is going to cover a large percentage of the population. The problem in PMJAY is that, and here is again where we can play a role, because PMJAY, what are they called? They create these amounts are currently unacceptable to many private sector hospitals, and that's a problem. And very often these hospitals are tending to overcharge above the package. So there is a sort of move to fund in the private sector, but I think also the private sector needs to play along, because the costing that Sonal talked about, there are so many notional costs in the private sector. And I maybe it is my inadequacy, but I've never understood what an ICU charge means notionally. What is it that in COVID people charge COVID charges, by the way, India's private sector, and I'm saying this openly, including hospitals I worked in Mumbai, during COVID put extra charges as COVID charges, as waste charges, PPE charges, and whatnot. So I think there is a lot of obfuscation of charges. I'm sorry to say this. So charging is a big Pandora's box. And so Sonal, you shouldn't be surprised if you get a cost between 8 to 30 lakhs.
No. So I mean, while we are at it, because this was the exact question, I'm getting a lot of questions in the chat as well. And certainly one of the things that always raises a certain red flag for me when someone says that a treatment is given free of charge, because there is nothing that is free of charge. There's somebody pays, either the taxpayer pays or it's cross-subsidized to somebody else, or X or Y pays. There is nothing that is available free of charge. So unless we actually assign true costs, we will not get anywhere, either in the public or the private sector. So Professor Rajesh Chandwani and I did a lot of work on this, and with two of his students actually, and we have come out with an activity-based costing model which factors all this in. I mean, to your point, Sanjay, what we were interested in was actually the drivers of cost in the public and the private sector, because a sector like, say, ILBS, which is a public, I mean, at least funded largely by the public, charges exactly the same for a transplant as I do. Yeah. In a private hospital. Although when we look at the bills, they're not substantially different. So it was very curious to me about what is sort of driving costs in different places. So the costs of what happens, like for example, what is an ICU bed cost? Hospitals don't have the costs of, say, building, electricity, water, sanitation, etc. That's captured in terms of a bed cost. Okay, and that varies differently from different places. And in fact, the value of that changes for a hospital. For a 10-year-old hospital, the value might be different from, say, a hospital that has just started. Okay, so when we look at activity-based costing, the idea is to capture every single unit of activity that has gone into this. In terms of what are the electrical charges, what is the square area that is occupied by a particular bed, how long is it occupied for, so on and so forth, and then come out with some number. And you're right about the point of it being notional, and then it gives you something to hang your hat to in terms of what are hospitals actually spending for. I'm not even counting profit, etc. in this.
Sonal, I'm just going to interrupt you. There's some interesting comment, but I'm just going to say that when you look at drivers, I think there's only one small issue there. There is also a driver called greed. So that how do you factor in a driver called greed?
No,
but anyway,
the point I'm trying to make is that greed is a lazy answer, because until we actually have a number, we do not know whether it is high or low. So, for example, if someone says free, we say, okay, well, I mean, great, let's get on the newspaper, give him a gallon, and that's fine. Fourth transplant free. How is it free? How is it free? No, what I'm trying to tell you is that it's a larger point I'm making, because unless you have a number, it's very hard to say whether it's low or high. If, for example, there is a scientific number, because this is mathematics we're talking about right now. If there is a scientific number, and I mean, I completely disregard that thing about, this is a surprising thing, Sanjay, because if you ask people what the unit cost of a heart transplant is, what the unit cost of a CABG is, most surgeons will not be able to tell you. If you ask an engineer what is the unit cost of making a Tata car, an Indica car, they will be able to tell you. I mean, why are we not doing that? Because unless we are doing that, this notional value, I would say the PMJ is more notional than what we are doing. How do they say that it's 3 lakhs?
Well, but except that
I think everybody knows the answer, Dr. Sonal. The answer is pretty well known. It's just not made public. You understand? I think every transplant unit works up the cost, because we have to ultimately see whether it fits the bottom line properly. So everybody knows the costs. It's only that the hidden costs are very difficult to assess in India. It's very obvious that the expenses during transplantation roughly falls around 1.5 lakhs. But the hidden costs are not calculated very properly. There is a lot of hidden costs in terms of bribes, licensing authority issues.
I mean, I was going to come to that. That we must publicly accept that a lot of it is referral fees. All transplant hospitals in India pay large amounts.
Dr. Nagral, I'm not talking about the referral fee. I'm talking about people taking bribe. See, in one of the hospitals I worked, there used to be a special fee column. What I asked, what special did you do for this patient to put that? And they said, no, this is for the bribes we pay for the lift, each one we have. The only way we can do is charge the patients. So I'm talking about those bribes, not the referral fees.
Right.
So those adds up a lot. Actually, in a hospital which has got 10 lifts, you really pay a lot. I don't want to open that Pandora's box, but I think those costs, the private hospitals do add up.
Yeah. I mean, Ilango, I think that all your points are valid. I think that, I mean, Dr. Amlo just put out that every procedure is well costed. I think that there are obviously a lot of values or points of view here. Certainly the point of view of everybody in India is that healthcare should be a not-for-profit activity. Okay, and that I think is the biggest dichotomy. And I mean, Dr. Nandi sort of just brought it out there in terms of differential value of human life, which was very bluntly put. But what I'm trying to say is that if healthcare is a not-for-profit activity, then the government should make substantial provisions for healthcare to be provided for people so that it is a not-for-profit activity. Now, the question is that now we're talking about, okay, fine, it is a for-profit activity, but is there any mechanism of costing it? What I'm trying to say is that there are objective ways of costing it without, which may not be, I mean, the idea is that unless you actually objectively cost it, you will not be able to convince either people to fund it. You will not be able to convince, Medicare or Medicaid or PMJ to support it. You will not be able to get any corporate responsibility or a CSR funding for it. So, I mean, hopefully at some point, perhaps we can get Professor Rajesh Chandwani here to present his data as well on the activity-based costing. We've done liver now. We're currently working on kidney at this time. And the idea would be that if we have a macro that's put up outside on a shareable website, then you can actually put in your hospital's bills there, and you can figure out how much is the difference from, say, an established mean that your hospital is actually charging. Okay, so I think that kind of transparency, until we bring that in, and we are responsible for that, as healthcare professionals, we have to do that, because until we bring that transparency in our costing, we can sit around here and talk about greed till the cows come home, but until we establish what's the correct number, we don't know what is the percentage of greed also.
Sonal, while talking on transparency, there was a point raised earlier in the chat box that even outcomes are not actually known. There are so many centers, and all people know is what is put in the newspapers, which is for want of a better word, a promotional activity where all the facts of the data are not out. So wouldn't that be one of the first things that should be done?
Yes, agreed. I think that one of the biggest shortcomings of our law, and which has not been implemented, has been the lack of transparency in reporting survival data. That's something that really needs to be addressed, because without, if again going back to the point of transplantation being a public good, when coal or electricity or air or power is used as a public good, we know what are the returns coming to the public for that. If organs are a public good, then we as a nation are entitled to know what is the survival outcome of those organs, and whether that public good is being utilized well or not. So I think that there are many reasons for quality data to be collected. Sadly, we have not managed to do that.
Please remember, the altruistic nature of transplant is inherent in our medical profession. All the doctors are basically altruistic. There are a lot of hidden altruism in day-to-day working in Indian doctors' activities. So please have faith and hope. We need people like you who have to think and keep on, refreshing the rest of the people. But as far as the work is concerned, kindly proceed with all that dexterity and skill, what you can apply in day-to-day life, surgical work. and the immunological aspects of transplants. Try to do something to bring down the pharmaceuticals charges of the immunological drugs. And with this sort of approach, I think we will be reaching somewhere very soon. And it's a question of not giving up hope. We can't correct the whole world at one stroke. We need people like Sanjay and our friend Sonal and all. Definitely, we need people like you to get into the topic, think of it. But please remember, in the medical profession, the altruism is still all there. There are a lot of hidden facts of altruistic activities by doctors at various levels going on every day in the hospitals, both in private and public sector, more in public sector. A lot of doctors are doing so many good things. So please have faith, continue doing what you're doing. That would be my request to you, because India is going on the technical aspect beautifully. With the robotic recipient surgery also in vogue now, the things are going on the right track. So I think we'll have to pursue and encourage the transplant team members not to lose hopes, have faith, and people who are very sensitive and who are aware to all the social maladies, please don't lose yourself in the hunt for that, because we are not social workers primarily, we are academic people. Please remember that and wait for the good day when everybody will get equal opportunities. Every public will have the right. They also have to be educated. Their role in a contribution to this, to achieve this, and their role is very big. And that is where the Indian government should pursue and see that education and poverty eradication both are maintained at the highest level, highest quality level. There will be answers to all this. Thank you.
Thank you. There are several comments in the chat, and Anand, for example, has many interesting comments to make. Is that Anand, as in Anand Bharatan? I'm not sure, but one of the questions is particularly interesting to me. It's nothing to do, I think, with transplantation, but this has been asked by Meera, who says that why do doctors charge and nursing charges change with the kind of a room a patient chooses? They are giving the same treatment irrespective of the room chosen. This is yet another. See, these are peculiar practices of Indian healthcare, and they have been given a free pass by the citizens of India. I am very happy to tell my patients that this practice is wrong, and that you please challenge it in court, because the same the operation theater is the same, the intensive care unit is the same, the drugs are the same, but you will be charged 4 times because you are in a single room. So please, somebody challenge it. Change in India has come by people challenging the practices of healthcare, and I completely agree. But if anybody else has a comment on this, these are interesting practices. And by the way, in hospitals in Mumbai, in certain types of rooms, you can charge what you want. It's called negotiable charge, and doctors can charge what they want. There's no upper limit.
On that note, I think there's so many more interesting points.
So yeah, but we need to.
Rajendra, your hand is up. It'll probably be the last comment for the day.
Yeah, ma'am. My three small comments to.
Chaube, please show yourself.
Yeah.
I can't see you. Yeah, there.
You see, Dr. Sanjay, I fully endorse the view of Professor Subramaniam. Your talk was fantastic, and the type of the words you used were to appreciate. But now, coming to these points, number one, you talked about the, mixing the brain death with the organ donation. This was all the things were started by Professor Nandi, and the members then were, it was in 89, 90 and 92, and the members were Professor Sunil Pandya, Professor Nandi, and the Mr. Srinivasan, who was the then cabinet secretary of the Central Health Secretary, and Mr. Alan Singhvi, the then High Commissioner of India to UK. And Mr. Singhvi, he was a very eminent jurist, and he advised Professor Nandi and the team that kindly do not combine brain death and the organ donation. But unfortunately, there is an inherent problem with when the rules are written or policies are written 2 to 3 years down the line after the a lot of discussions have been taken. But unfortunately, when the rule came, they were mixed. That is one point. Secondly, coming to the your brain death and end of the life treatment and the cost. You see, second time in this HOTA or THOHA, that was in somewhere 2008 to 2010. And in those discussions, it was decided that all hospitals, wherever these retrieval, the centers, the hospitals which will be recognized for retrieval only, the brain death will be made mandatory. It will not be connected to any fellow whose brain dead. It should be endorsed in the in a case sheet, in a document. But then again, it has not happened. Thirdly, as far as the ethics, particularly for live donor liver transplant, in a very famous hepatologist, Professor Alvin Elias from Queen Elizabeth Hospital, Birmingham. He had come to Armed Forces Army Hospital Research and Referral in Delhi, and he during his talk he told that all your life, right from the first MBBS till all the medical education you get, you are trained and taught to treat a patient. And in a liver, in a live donor liver situation, you are making a normal person a patient, which is never taught to you. And this is a peculiar situation where a normal person is being made a patient. This 0.1% risk is, he says, so from that day, I have dealing, ever thinking of relating, saying combining ethics, applying ethics to live donor liver transplant. There is no ethics, to my mind, there is no ethics related to live donor liver transplant, because it's all against the basic tenet of medicine.
Okay.
Your closing comments, Dr. Sanjay.
No, I think we've already had a lot of discussion, and I don't really have anything new to say, but just to say thank you. I think the fact that we are all here discussing for 2 hours by itself is hope. The moral arc of history moves towards justice, right? I think it's Martin Luther King. So the question is, should we do our own little bit to push it in that direction? That's my closing comment.
Thank you. Radhakrishna, when you first suggested that we should get in touch with Dr. Sanjay to talk about medical ethics, did you have anything like this in mind?
Well, this is a lot less than what I expected. Sanjay is, when actually we were together in Dr. Nandi's unit at that point of time. He's someone, I think, as Dr. Subramaniam keeps saying, that he is the one who pushes the cover as much as, and I think, the whole country should listen to him.
Yeah.
Of course, it's a privilege and pleasure to have Dr. Amlar Panathan and Sonal, and the final word by Dr. Pradeep Chaube. It was wonderful.
So, Dr. Sanjay, though you consider the topic of medical ethics boring, but I think we will reach out to you sometime in the future, and something more generalized about professionalism vis-a-vis ethics in medicine is a very much wanted subject to be discussed, and we'll try and get as many youngsters as we can to log into that session, because I think there is a challenge about not having good role models to learn these things passively. So thank you so much for joining. Thank you everyone for staying here for nearly 2 hours. Thank you, Sonal, for coming immediately after a long day. And thank you all for this wonderful discussion. I'm sorry, Venkatesh, we couldn't give you time to speak more. Anand, you were also extremely provocative, and I think that's very much required to, push the envelope, as Radhakrishna said.
Anand was accurately provocative. So,
so we'll meet again next week with yet another episode of Marvelous Medicine. Till then, take care and stay safe. Good night, and thank you again.